bring it up. Okay. I'm sure you read your textbook, or you will, dementia. And I saw some, I want to tell you a story because I just saw that. I haven't seen this in I don't know how many years. I have a patient from Papaico. Papaico. You want to tell them where that is?
It's about it's about 15 minutes outside Hilo, along the Hamakua coast.
50, right?
Oh no, I would say 15. 15.
15. Oh, somebody told me it was an hour. Okay.
No, it would take from Papaico to Hilo Medical Center. You're looking at maybe 20 minutes.
So, gee, how many doctors do they have in Papaico? Any?
I don't think there's a clinic out there at all.
Yeah. I don't know where this guy's going. The case manager called me on my way over that I finally got a hold of to find out more. We got very little information from Hilo Medical Center. It's a trauma case. So trauma cases come to Queens, and geriatrics is consulted. We take over medical management because the trauma teams are surgeons. And anybody work in surgical services? Before I say anything else? It's a different world. It's like, so, but we work pretty well together or in parallel, something like that. Mostly we call the nurse practitioner or the PA, or the social worker or the case manager. We don't really call them too often. And there's residents that do a lot of the prescribing, so we've got to watch them too. So these are objectives. And mostly it's going to be listed off because you're going to have to look it up anyway. If you don't know, what are the laboratory tests? And what's the blood test for Alzheimer's disease? All right, no blood test. Okay. But we do two blood tests, right? Why do we do blood tests then if there's no blood test for Alzheimer's?
To rule everything else out. Yeah.
Yeah. So we want to see what else is going on with their metabolic stuff. And typically we're always going to check thyroid too. And for older people, feel free. It's very easy to justify checking thyroids, and you should, because there's a lot of hypothyroidism. There's a lot of B12 deficiency in the elderly for a variety of reasons. Not too many people that had those subtotal gastrectomies in the past, but there's a few. But if they're taking PPIs, or they have, because they have ulcers, they're taking PPIs. People on metformin become B12 deficient too. So there's this loss of intrinsic factor because we've changed the pH of the stomach. Super common, super cheap to treat, and it's super important because even though they don't have anemia, some might have anemia, but sometimes the folic acid in our diets correct it, and but they will still get the neurological deficits from the B12 deficiency. So it can be muscle wasting, it can be cognitive. We see depression. I've seen psychosis. Treat B12. I mean, or just take it. But we check it. And then vitamin D, that's really been in the last 15 years. 15 years ago, we weren't checking vitamin Ds. I mean, in Hawaii, why would we check a vitamin D? There's enough sun. What's the problem? And then we started finding it in nursing home bases. Well, they never go out in the sun. No, it doesn't matter. As we get older, and probably more so in Hawaii, because our skin is damaged, the skin organ is damaged, and as our kidneys decline, you see more and more D deficiency. And it makes a deal. We used to think of it as just bones. It also is important for muscle function and for cognition. So Alzheimer's is the most common type of dementia. It's about 60 to 70% of all cases. If you add up all the numbers for all the different types, it comes up to more than 100%, and that's because a lot of people have more than one. These numbers are getting a little bit old. 4.5 million people in the U.S. Will get this between the ages of, or 3% of people over 65. Actually, by the time you're 70, by the time you're 80, the chances of having an irreversible dementia, total chance is about 20%. By 85, it's almost 50%. Hopefully, with a healthier lifestyle, we are starting to see some of that decline a bit. Especially we see, we've decreased strokes. So that's a big deal. But Alzheimer's is not necessarily spared, but lifestyle still is important. And there's some interesting stuff coming up. Still some hope for us. The other common dementias are vascular dementias. 10 to 20% of cases overall for the United States statistics. I think it's higher in Hawaii. We have a lot of cardiovascular disease, a lot of hypertension that leads to vascular, small, you'll see it. Sometimes it's not even a stroke. They call it mini strokes, small chronic vessel ischemic disease. If you see something that says lacunar infarcts on a brain scan, that's what you're looking at. And if you look at the risk factors, you're really going to get pointed in the right direction. What are the risk factors for vascular dementia? Diabetes, metabolic syndrome, hypertension, definitely. Diabetes is. What else? A big one. Atrial fibrillation. 17% incidence of stroke with atrial fibrillation, which can be reduced with anticoagulation, and I'm always very concerned about that. But you got to look at everything. How bad, how bad is the dementia? What are their goals? What's their other function? Frontotemporal dementia is fortunately a lot less common, but it does show up, and we do see it in the hospital more than we care to. And this can be, I have another slide for that. And then Parkinson's disease dementia I talked about already, and then the mixed dementias. What is dementia? So, what do most of our families tell us, Christine? So, when did you notice her memory problems starting?
Just recently, because she remembers all the family members and does her own finances.
She knows who I am. She was perfectly fine. When did her memory problems start? Oh, she was fine before she went in the hospital. I mean, this happens to me almost every day. They were fine. He was independent. He was doing everything for himself before he fell and broke his hip. And he's cachectic, and the muscle waste is like, this did not happen in the last week. There's no way. And sometimes, sometimes we have patients that, they speak another language or they have some aphasia, but the families think they were fine. Well, how was he getting food? Well, he must have been going to the market and eating, cooking. I think he cooks on the stove because I saw food in the refrigerator. Temporal wasting, you can see the chest. We could see the wires from his cabbage under the skin sticking out. So you kind of have to reframe it. But you do. So that's where getting functional information is very important and finding out. One of the quicker ways too, and it's not foolproof, but asking, more things like the activities of independent living, like telephone use, shopping, meal preparation. Oh, and who does the finances? Oh, I do it. How long have you been doing that? Oh, about 5 years. Oh, how come you took over his finance? Who did it before? He did it. But you took over 5 years ago. And it does not occur to people. This is almost universal that there was really something wrong. They just, they're getting old. So when we look at how do you approach this, and if you walk in to every patient's room thinking you're going to do the same thing, you are going to have a rude awakening. I got fired last week. I got fired twice by the same patient. The attending keeps calling, could you please help me? She's another story. She didn't like having any cognitive testing. And actually, the first day, we didn't even get to the cognitive testing. I had a medical student with me, and I thought, I'll have him start just kind of interviewing her and just warm her up. And that's something you want to do, get connected with the person, like, where are you from and what do you do? And by the way, how old are you? We had one that said, we asked her that question. So how old are you now? And that'll be one of my, it's like, where are you from? And it's like, oh, and by the way, how old are you? Well, I was born September 29th, 1927, so you figure it out. So where do you live? Here. So people that live in Honolulu all the time will typically, they will know they might tell you the right thing because that's long-term memory and they haven't moved. But neighbor island patients will, if they've got cognitive impairment that's very severe, they're going to tell you either they don't know at all or they're going to tell you, here is Hilo, if they're from Hilo. And right now I have a bunch of neighbor island patients. So I do the interview to find out, do they know where they're from? Do they have any clue where they are now? So, and what brought you to the hospital? Why are you in the hospital? That can be very telling. You can get the story from them. What kind of education level did they have? And here it's typically, so where did you go to school, right? What level, you don't want to say what level of education. That sounds judgmental already, right? So, where'd you go to school? And you will really be amazed at some of the things people will tell you when you start warming them up and then you start kind of digging in and try to get a little more information about where they are before you start any formal testing, because you may not be able to do that, especially with stroke patients. And then we had not a frontal temporal dementia patient, but it was just a temporal dementia. And we started asking this guy questions, and he seemed, he was pleasant, he was connecting with us, but he had a really hard time expressing things, and he would get really frustrated. And then he was starting to get agitated. And I told Christine, I said, let's go to the paper and pencil thing. And I wasn't sure what we would see because we do visual spatial skills. And he was able to, not only could he write what he wanted to say, it was very neat. And things we could not get out of him verbally, he was able to write. And then if we asked him, like, well, do you know who your doctor is? And he would pull out these notes. He actually was, his short-term memory was still bad, but he was compensating with some things. And that's really consistent with that temporal lobe. It's called, and he had echolalia. So if we would say something, he would just keep repeating it back and back and back. And what's that? What's next? What's next? Yeah, so I don't know that I've ever seen anyone that clean of, no frontal deficit, but all temporal, and very interesting. Unfortunately, he was also very sick when he came in with hepatitis C and probably a lot of other things from being homeless. So, and then, today I had another stroke patient. It was obvious he had a left middle cerebral artery stroke. Only 61. I'm going, trauma team, 61. How come they're calling me for a 61-year-old? That's not old. But, sometimes that is old, right, when you have multiple organ deficits. So, again, just trying to look at what we could do with him. He could answer yes or no, but very little more, and sometimes other things would pop out. So a lot of yes, no, but very simple, one-step things, only answer one step at a time. And we got a lot of information out of him. But I did a lot of phone calls, too. It's still extremely unclear to me why this man is on amiodarone and doesn't have any history of atrial fibrillation in our records. And I don't know why he has that sternotomy without a diagnosis of, coronary artery bypass. It's like, and on and on. And there was something about pacemaker. Anyway, so we were in, I wish I could show you the clock drawing. We had him sometimes I use a whiteboard. It's too hard for them to hold a little pencil. And the whiteboard, sometimes people do very well on the whiteboard. And so I drew the circle, and he put a 1 at the top, he put a 3 where the 3 should be, and then on the other side he put a 9 upside down. But typically, now he's got right-sided hemiparesis and dysphagia, so he has expressive aphasia. He can't swallow now, so he probably was not eating when he first came out of the stroke. Probably was tube-fed for a while. And he does remember the puree. Oh, he got more expressive when I talked about puree food. Like, oh, awful, horrible. He knew all the words for that. Like, okay, we're not going to go there. We're not going to give you any puree food. Okay, that's all right. So you want to sort of get the lay of the land. And educational level does count. We had a patient not too long ago was from Arkansas, and he had a 3rd grade education. And he said maybe a little less than 3rd grade. But as you interviewed him, you really got a sense that he wasn't demented. And he needed a TAVR. He was in his late 80s, but he needed this, we do the trans-aortic valve, transcatheter aortic valve replacements. And so geriatrics evaluates these people when they're over 85, sometimes younger too. So we used the Mocha Basic with him, and that was really good. So I've only used that one a couple of times because I just found it recently. And one of my patients that had a lower level education, but he was 7th grade, but he has brain damage from meth, probably. He scored 17 over 30, which I was really surprised. But his short-term memory is 0, but his attention is good, and he can talk to you. He can tell you some of his wishes. But the late 80s guy that did the Mocha Basic, which was totally appropriate for this guy, he scored 28 over 30. So it really adjusts for educational level. And I find that a very useful tool. I'll show you that. So some people, so 28 over 30 is considered normal. When they're, like 26 on the Mochas, it's considered to 24 to 26. We call it mild neurocognitive disorder. And so that's in between. That, it could be other reasons that they're having some deficits. Maybe they're just a little anxious. Maybe they're too tired. Maybe it's medication. Maybe they're a little sick. But many of them do convert to dementia. Deliriums. I've got a table, but basically most of you know what delirium is. They're confused, but you cannot diagnose a dementia in the presence of a delirium. And this is typical for post-surgical patients. They may have cognitive impairment, but you still can't diagnose anything because it may be the anesthesia, maybe some of the other medications, pain, Foley catheters, constipation. All those things can cause older people to be delirious. And unfortunately, that also causes them to have restraints and mitts, which make it all the worse. And it's really just amazing if you can get the whole team on the same page about getting rid of the catheters, controlling the pain. We have, too many PRNs. It's like I go around and schedule more people on pain medicine in the hospital than I think I should have to. They're very shy about giving it. So they're disoriented, but once they do get something, like you can go over and over, you can get them to register something, they probably will remember it. But typically, they just can't pay attention to anything. So when we do these cognitive tests, there's sections that are listed. This is attention. Can they actually stay on the task and complete the task? It can be an easy task, and anybody can do it if it's easy. But if they're delirious, it's not. So things like attention task might be serial 7 subtractions from 100. We will have them tap when they hear the letter A, when we read off a series of letters. Repeat this number series after me, those kind of things. Those are for attention tasks. So some call it acute confusional state. And also we have to look at the drugs. Drugs. All those anticholinergic drugs, Benadryl, it can be the antipsychotics can cause some of those. Even olanzapine, which is an atypical antipsychotic, actually has quite a bit of anticholinergic activity. All the over-the-counter cold medicines probably have anticholinergic activity. Those drugs for Parkinson's tremors, Cogentin, Artane. And the big one we're seeing now a lot are the drugs for overactive bladder. Okay, the prototype is ditropan or oxybutynin, very anticholinergic. And so anticholinergic makes them constipated. So again, so they're going, I want to go shishi, and you think the answer is to give them anticholinergic drugs, and it's usually doesn't work very well. When it's a brain disease causing that, you need to get rid of it. And then again, we are looking for certain antibiotics, particularly Cipro, and cefepime is another antibiotic that causes a lot of delirium in the elderly. Okay, so we've kind of gone through some of the differential already, but you're looking at those features. And Alzheimer's, and here's the big difference between, if you can get the history. Most of the diagnosis is going to be guided by the history. You're ruling out problems, but you want history. So interviewing family members. And the thing with Alzheimer's is it's so insidious. It's progressive. And it never stops progressing. You might slow it down with some of the medications in the early stages, but it's just a steady progressive. Whereas with vascular dementia, we call it a stepwise progression. So maybe they have a little stroke and they go down, but they tend to get a little better. You know, they'll suddenly kind of stop talking, and you'll get these histories from families. Have you ever seen that? Has she stopped talking? I mean, you ask them about slurry speech, loss of hand or arm, it's usually not there. But if you ask them about, well, you ever just seen pauses when she was just standing there not saying anything, and then more confused, and yeah, that's how she was. And then she got better. But they never really get back to the baseline. And you do the CAT scans, and you see these reports of small chronic vessel ischemic disease and lacunar infarcts. So that's the difference. More visual spatial problems with vascular dementia patients. And I'm going to show you some examples of what that looks like in a minute. We're looking for those vitamin deficiencies. Depression, especially in stroke patients, there's a lot of depression. There's a lot of depression in aging. There's more depression with dementia. And with vascular dementia is the most. Lots of depression. So we use lots of antidepressants. And sometimes that's the key when we would say, well, the consults, because they've got a dementia with behavioral symptoms. At least we got them saying behavioral problems. But that's, and they respond very well to some of the antidepressants. But we have to be careful. There's cardiac issues, electrolyte issues. They are still psychotropic drugs, but usually not as, you get more benefit than harm compared to an antipsychotic. But sometimes we have patients in the psych unit that we also do the medical management for, that because of where the strokes are, and it's usually the frontal, when it affects the frontal cortex, they're managed on antipsychotics. We try other things, and I'll talk about that in a minute too. Some of the risk factors, again, the medical, AFib, hypertension, diabetes, those are the main things we're looking for here. Drugs, educational level, you're just going to see different, you just have to adjust for the testing. And it's not that there is the incidence of dementia higher. Well, we probably see it earlier because people with higher level education and function cover up better longer. And everybody around them covers up for them longer. And I don't know about you guys, but in my life, we are all guilty of doing that, especially for people that were really high functioning and held in high esteem. We don't want to admit that they're demented. Or it's the elephant in the room. Drugs. Oh, I have one drug in mind there. I mean, how many drugs actually cause dementia? Anybody want to take some guesses? It's okay. There's no wrong answer, but just put it up for. What can cause dementia? What kind of drugs? Maybe indirectly.
Didn't a study come out saying that PPIs can, long-term use
I
can
saw that
cause
recently.
dementia?
I haven't really read the original articles on that. And I don't know that's because of the vitamin B12 deficiency or there's some other mechanism, but it's something we need to keep an eye on too. What any other drugs you can think of? What about benzodiazepines? Yeah, they can. How many of you have worked with somebody that's on benzodiazepines chronically? How did you feel?
Yeah, let me press my button. Not good.
Yeah, how would you describe that person? I mean, just be honest. One word.
Impulsive. What's my best word for that? Just kind of, I mean, scary is kind of,
Scary.
I would describe it, but
I would use the word nasty.
okay.
I mean, I've been doing this for a long time, and every benzodiazepine addict I've seen, and of course they do not consider themselves addicts because somebody prescribed it for them. Why do people prescribe it for them? What? Ask. More like demand. Demand. So is it it's an anti-anxiety drug, right? Sometimes they use it as a muscle relaxant. It's a slippery slope. This drug is horrible.
So when I think of dementia, I think it's non-reversible. So when you say someone who's been chronically on benzos, you're saying even when they get off of it, the damage is done. Okay.
Long-term. It's probably long-term use with the long-acting ones, yeah. And they probably had, maybe, I don't know. I don't think they all had dementia, to start with, at least. But definitely that is known now that there is a benzo dementia. But the problem is it gets prescribed for one thing. And I mean, if for a very short term, for somebody that's extremely anxious because someone died, they can't sleep, you know, it's okay. And we do occasionally use it in the hospital for somebody that's delirious, or it's the risk and benefit. But too often it's prescribed for people for sleep. And you still, I mean, and I'm shocked to see how many people are taking these drugs on a really long-term care basis. And it's very hard to get them off it. And you can't just stop it cold turkey. They can have very severe withdrawal symptoms. Getting people off of benzos, the withdrawal symptoms are worse than opiates. Yeah, bad stuff. That said, now for a seizure, you don't have anything else, okay, I'm going to use what's in the e-kit, and I'll use Valium for seizures, active seizures. That's not the point. It's, you know, this long-term thing for sleep, anxiety, and they think they need it for sleep, but it doesn't help after a while. They get a rebound insomnia, but they will tell you they have to have it. And I've seen situations where, I mean, they basically blackmail their doctors. They want those drugs. Anyway, so drugs, so mainly the benzos, well, I think meth, maybe indirectly. Yeah.
I was gonna say alcohol induced.
Yes,
dementia.
there is an alcoholic dementia. I didn't really put it as one of the differentials because even with alcoholics, we don't really see the symptoms, what they call Wernicke's dementia. But definitely there can be an alcoholic dementia. But most of the time, I think what we're seeing is a vascular dementia that because of their poor nutrition and hypertension and not taking care of their chronic diseases is very common. You know, they're not taking their cardiac drugs. They're not taking their hypertension drugs. So they do develop vascular dementia, and that's really what we're seeing primarily, but there's probably some damage. But, you know, there's certain clinical criteria to diagnose Wernicke's that is really not that common. But good thought. And alcohol certainly causes a lot of problems. So this is just a way to think about, well, are we looking at a delirium, a depression, or a dementia? And what's the onset like? How long has it been going on? Any psych history? Fluctuating. Depression can be fluctuating. Dementia is stable, but day-to-day it's progressive. And with delirium, it's short and long-term memory loss. They can't do anything, but once they get better, their short-term memory is okay, and their long-term gets better. With depression, it's both. But the thing about depression is often they will be pointing out their deficits. And so you'll ask them, you know, you remember those 5 objects? And say, see, I can't remember anything. Whereas the Alzheimer's patient will guess, make it up with a smile. You're like, and if they don't get them, we give them category clues, and then we give them multiple choice. And they'll just start making things up. That's so Alzheimer's, you know, and they're trying to hold the integration of their person together. So when you do the testing with them, you don't want to say, no, that's wrong. It's like keep everything positive. Start it off saying, this is, you know, this is a standard test, a standard assessment we do with everybody. There's no flunking. Some of the questions are really easy. Some are harder, but almost nobody gets it all right. So don't worry about that. So because if you let their anxiety get away from them, it's going to become, they'll shut down, they'll fire you. Okay, I've been doing this for a long time, and I got fired last week. The benzo lady. Yeah, she doesn't like that. And very interesting. She has had a stroke, and it's really hard to tell what her cognitive deficits are. And I still don't know, but I did finally get her to do a clock drawing, and everything was in the upper right-hand quarter of the clock. But within the quarter, it looked like the left hemi deficit patient. So, and I have some pictures I'm going to show you in a minute. But yeah, and sometimes there's going to be depression in dementia anyway. And I have a couple, besides the geriatric depression scale, I really like the Cornell scale for depression and dementia, because you can go through with family members or caregivers that can tell you the observations that can tell you and justify this is looking like a depression. Yeah, there may be a dementia, but if you treat the depression, you're going to get a lot more bang for your buck than Aricept or galantamine or any of the drugs for Alzheimer's disease. Okay. They'll function a lot better with antidepressants if that's what the problem is. I'm not going to go on this site. You do have to register for this site. It's got a lot of really great resources on there for delirium, dementia. There's some videos. There's charts, drugs that cause delirium or dementia, and the videos. It's free, but you just have to register. Okay, so again, the dementia workup, mainly it's the history, and you're going to get a lot from the family. We have a checklist that we use, and especially when I'm doing the cognitive testing, when I don't want the family to jump in, I give them some homework to do. Here, I give them the ADL stuff to fill out and the behavioral cognitive checklist, and that works really well, usually. And once they see the list, it's like their eyes start opening up and going, oh, yeah, that's what we're seeing. Again, history, these are the list for, the left side is the ADLs, activities of daily living. The right side are the instrumental activities of daily living. So those are the higher function things. Those things go first. And usually managing finances is the first. Unfortunately, transportation, driving is not the last thing to go. It should have been earlier, right? So that's another thing we have to deal with. They're driving, really? That's a really good time to pull out the clock drawing and show the family, seriously, do you think this person should be on the road? So, okay. Any questions, Jen, Haley? Okay. Neurological exams. Again, there's lots of things you can do with the neurological exam. I typically always do a cranial nerve check, sensory exams. You want to know about vision and hearing because you're not going to be able to communicate if you don't. Now, deep tendon reflexes, I'm just looking for asymmetry, okay? In older people, if you don't find any DTRs, don't freak out because you're not going to find them most of the time, especially in the heels. Just don't worry about it. But when you see, so my new stroke patient, not new stroke, this is a trauma patient that had a stroke a few years ago. You can see he has the right hemiparesis and he's got a washcloth in his hand from the contracture. If I wanted to show the medical students, like, let's do some DTRs. And yeah, hyperreflexia for him. So that's really common. It's way past. You don't really see a Babinski on him. But you do want to check for those things. And symmetry. So get with the cranial nerve checks. When you have someone smiling, look and see. Look at the symmetry. Make sure they didn't have Bell's palsy to explain that. Okay. The 3 tips. That's the informed, informal interview. Like, again, getting somebody, establishing some rapport before you start asking all these invasive questions is very important, and what your role is. And this is, we already kind of went through this. Don't use the word test. They get really anxious. And again, as you're going through it, they'll want to, did I get that right? That's okay. Don't give them the answer. Don't tell them it's wrong. Just say, you're doing okay. That's fine. And if you see they can't complete a task, move them along so they don't get so frustrated they can't function. Okay, I will just show you this one at least, because we use this one a lot. And since this also comes, there's a website for the Montreal Cognitive Assessment, MOCA, and it comes, actually there's 4 versions now. It's A, B, C, and the MOCA B, which is the basic. So this is the visual spatial skill. We have these things enlarged that we can use because somebody, I mean, when you're walking around the hospital and they don't have their glasses and their vision isn't good, it's good to have these things enlarged. So like I have 3 pages just for the trail making, the cube, and the clock drawing. So, and the instructions here is begin at the number 1 and you're going to draw a continuous line from 1 and alternate numbers and the corresponding letter. So it's like 1A, 2B, 3C, and so on. So they get the pattern. And you can guide them through 1 and 2, and if they're having trouble, you're going to have to still guide them because they want to do it. They want to get it done. They want to get it right. So that's fine. But if they're getting it wrong, you have to take them back. But if they're getting frustrated and they've made a couple mistakes, just move on or let them finish it any way they can. I'm surprised at how few people can get this cube. It's like they were never taught to draw a cube the right way. Okay. And here we do, I'll do it big on the back, draw a circle. You can draw the circle, that's okay. Put all the numbers in, just like the face of a clock, and then I'll tell you where to set the hands. So we do it in 2 steps. I used to do it the other way, and it's like, of course, they could never remember. And it's not just that's not a memory thing per se. It's really a construct that we're trying to get them to do. And I'll show you some examples of that that get pretty interesting. And then we want to know if they can name the animals. Well, we don't have these animals in Hawaii. Well, I don't have them any place in the United States except in a zoo. Right? Lion, most of them get the lion and the camel, and we get all kinds of answers for the rhinoceros. Hippo, cow, bear, buffalo. Well, I think it's relevant in the fact that, like I say, these don't exist in the United States at all. So, I mean, most people have seen books, and so that might be, they don't use this. You know, there are some objects on the Mocha Bee. I mean, but everybody has seen pictures and know what things are. But they're not. Yeah, so anyway, we want to keep it standard. And then we do registration of objects. And I tell them, and I mean, this is the way I do it consistently. I'm going to tell you 5 objects to remember, and then I want you to say them out loud so I know you heard them, which is true. And then I'm going to have, and I do it one at a time, and then I have them do all 5 at a time. I don't know. That might be wrong, but I don't want them to get too frustrated. And it usually, if they're really Alzheimer's, it's going to, the result's going to be the same. So we do that. And so remember those, because I'm going to ask you again in a couple minutes. And you get this look of like, like, okay, we'll go on. Let's try this. So read them the number. That one's forward. The second one is backwards. Sometimes they'll tell you the same number. You give them one more chance. And then the letter, reading the letters, only tap when you hear the letter A, serial 7 subtractions. And there's, you know, this one really depends on what they could do before. If they could never do subtractions, they still can't do it, no matter how demented or not demented they are. And if they could have done it before, like our tax lawyer friend who's back again, like the 5th time. Memory is 0, but he can do the serial 7 subtractions without a hitch. Got to go to another version with him tomorrow. Yeah, I got to go back. We got another call by another doctor. I hear you know this patient. It's like, yes, okay. Repeat these sentences. And then the language also includes fluency, which is naming words that begin with the letter F. The slums uses animals. That's fine. Then you do comparisons, recall, orientation. So you wind up with orientation, which some of them can do some, so they feel pretty good. On the clock, just to go back and talk about that. So the numbers, some of them will get all the numbers, but it's amazing how much difficulty they have with the construct of setting the hands at 10 past 11. St. Louis University mental status exam is another. It's a little, you know, the mini mental state exam that we used to use. Everybody used it forever. It was translated in 1 million languages. Everybody across the country, across the world was using it. Then some person decided to copyright it. It was not the authors. Somebody got the copyright. I don't know how they did that. So they were going to charge for it, and everybody said, phooey. So we started using, I can't remember which one started first, but in my clinic we were using St. Louis University mental status exam, which is more sensitive than the mini mental state, so we like that, but it's not as sensitive as the MOCA. And then the mini-cog is just for screening, basic screening in primary care. 3-word recall, so you give them the 3 words. I'm going to try to remember these words. I'll ask you again in a couple minutes. The clock drawing and the word recall. So here's some clock drawings. So we did all the numbers. Now set the hands at 10 minutes past 11. So this is probably vascular, but you can't really tell. You see a lot. Now this one, you can't see the whole thing, but you can see the numbers just keep going and going, but it's all on the right side. So it probably is definitely vascular. Not only do you see a left-sided neglect syndrome, you're seeing, what do you call it? They just keep going and going and going. It's perseveration. I'm pretty sure that's vascular. This one also strokey. Look at that. Start at the 12 and they go 1, 2, 3, something, 6, 4, 9, 11. What? And then look, they're looking for. Put the number. Can you set the hands? I mean, I just like to see what they can do. The concept is just. And these are people that grew up with analog watches, right? So someone asked, well, what about these young people? Say, well, they're not demented yet. I don't know. I'll be gone. That's their problem to figure out. Okay, so they wrote something here, 10 something 11, and then they just so they wrote it down here. Yeah, it does. It looks like it, but I don't know if that's what it means. Then this is another good example of perseveration. Oh my God, it's like, he would never stop. So I didn't ask him to do all these hash marks, but he put all the numbers in first, and then he went back and started going, tick, 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 and I could not stop him. Yeah, yeah. These are long consults. Again, the labs, I think we try, basic metabolic stuff, but plus the TSH, vitamin B12, D3, if they're on drugs. Now, hopefully we don't see too much of this junk anymore, but digoxin we still see in the hospital sometimes. That's a really toxic drug in older demented people. Now sometimes it's not possible, but it does not have to be in the toxic range on the labs to be toxic. Especially as their kidneys get worse, this drug is circulating forever, and they're toxic, and they don't eat, and they're dying. So we're killing them with the digoxin. So you got to pick your poison. Theophylline you hardly see anymore, right? Valproic acid, you're not sure what you're seeing. You don't even know why they're on it these days because it has so many uses. It's an old anti-seizure drug. It's used for behaviors, which is really not Hoyle. It is FDA approved for bipolar disorder, and again, we do see it for some of the behaviors. But there's a lot of problems with that drug. The tremors can be really bad, but the most common problem I see is thrombocytopenia, so because of the liver. So you do need to check liver function, but you're going to see it in the platelets probably long before you see any liver enzyme problems. And it can be dramatic. So you have to take them off. So let's not even go in that direction anymore if possible. Dilantin. Anybody know Dilantin? Have you seen anybody with Dilantin lately? That's a really old, terrible drug. Really hard to keep in therapeutic range. And it also, they get really bad gum hyperplasia. And that's how a lot of them lose their teeth, or used to. So we check their liver functions, and then just the starred ones are, if it's indicated, RPR, which is the reactive plasma, I forget. Looking for syphilis. So it's a screening for syphilis. If it's positive, then they have to do the titer. And then it goes to DOH. And the labs, that's all set up with the labs here. HIV, if indicated, drug and alcohol levels. They do tox screens on everybody in the emergency room at Queens, but you can be fooled. It can look negative in the emergency room, but it's not that they weren't doing any meth or alcohol, maybe not immediately. It's only like in the last 24 hours or less. So again, ruling out things. Chest x-rays may be indicated. Urines, again, please be careful with why we check urines, because once you do one and somebody sees it, and I can't believe how many people we treat for asymptomatic bacteria in the hospital with IV antibiotics, and they don't have a UTI. And I look at the cultures, and everyone's arguing. I mean, it's a big DNP project, I think. Several people could work on that one. We have another one, too. Sliding scale insulin. That's another one. Now, when the B12s are just sort of low normal, and someone says, they're not anemic, it's not a problem. Check a methylmalonic acid. It's more sensitive. It's a kind of expensive test, and it has to be sent to the mainland. But again, super low B12s or, a prolonged B12 deficiency can cause a lot of neurologic damage that doesn't have to be. We do a lot of neuroimaging. If you get a really good history and there's no focal deficits and it totally sounds like Alzheimer's, you really don't have to do a CAT scan. But here, the reality is everybody gets a CAT scan. Okay. So these are the DSM criteria for Alzheimer's disease. And I think you can put it together from what we've talked about. So these cognitive deficits interfere with independence and activities, everyday activities. But early in the disease, it's there, and some people are functioning quite well. They will self-report it sometimes in the beginning, but I'm always looking for something else. And I'll just tell you a personal unfolding case study with my own family member. I have an older sister. She's 10 years older, and she's been complaining to me for over a year about memory problems. And our father had Alzheimer's disease starting at age 72 that I diagnosed. It took me 10 years to get his doctor to agree. He really did have Alzheimer's disease. But I finally went out there, visited with her, and spent 3 full days with her and looked at her medications. Polypharmacy, vitamin D toxicity. She got referred, now this is kind of a sort of a rural area in California, got referred to a rheumatologist for aching, joint muscle pains. What else do you think she could have been on? What? Statin. Yeah. It wasn't a super high dose, but hello. So this rheumatologist prescribed her vitamin D, 50,000 units, twice a week for 3 months. Maybe it was every day. I wrote it down, but it was like, I couldn't believe it. And then it was going to be once a week. No, actually, I think it was every day for a while. Yeah, it was every day for 3 months. And then twice a week. And then once a week. What? No, 50,000 units once a week. She was taking it every day for the first 3 months. And then she did decrease it to twice a week. But the bottle continued to say twice a week. She's now been on it for 12 months. 50,000 units twice a week. And I said, let me see the bottles. And there it was. It was still on the bottle. And then she pulled out, because her list said every other week. And then she pulled out her notes from the doctor, which it was going to decrease, but it was still way too much. And you can become toxic on vitamin D. It's a lipophilic vitamin. So she was also on wrong antidepressant, statin, and Vesicare for overactive bladder. It's like, okay, we gotta talk about this. Yeah. So I'm hoping she'll feel. So we got it changed. So and she was on Wellbutrin, which is that's not a first line antidepressant for anybody. And they had started her, but she was still depressed, so they put her on Lexapro, but a small dose. So I said, how about increasing the Lexapro and getting rid of this stuff? Stop the vitamin D. And I said, well, and I wrote up a 1-page report, no, probably a 2-page report. And there was a nurse practitioner in the practice, so they did start on that, and I'll be checking. So I'm hoping that she'll get better. I think she will. I mean, she still functions pretty well, but I lost my car the other day. It's like, and I lost my keys. Well, she misplaced her keys. I put a tile on my office keys. I don't know. My car keys, I'm fine. I don't seem to lose my car keys or misplace them, but my office key is always in the wrong pocket, so I put a tile on it. I just gave one of those to my chief. She's worse than me. I'm losing the keys, so that's criteria. We talked about this. So when we talk about focal neurological signs, hemiparesis, that's a very obvious one. Lower facial weakness, so you see that asymmetry in the smile, Babinski signs, sensory deficits, dysarthria, and then evidence on the brain scanning. So just a little bit about Lewy body. So Lewy body is a lot more common than people think. And so now I'm in the hospital, and I am seeing a lot more, but the differential is very tricky. So right now I'm working with a guy that has bad vascular dementia. He was very athletic, was a surfer until a few years ago, golfing. I don't know how he got such bad vascular dementia, but it's affected the parietal and occipital lobes. So we are seeing some behavior problems, and he hallucinates. There's a Lewy body differential for this guy because of these visual hallucinations. But the more I listen to the family, there's more than just visual hallucinations. There's delusions. Those are both consistent, and especially in the occipital lobe, that's probably going to cause some problems. And he doesn't have any Parkinson features, and he's quite advanced in his dementia. So he can get up and walk. He has been having falls, so we're looking at a variety of issues cardiac-wise and medication-wise on him to see if there's any problem with that. And but he's vascular. But so Lewy body patients, but the hallmark is, this is it, and how you differentiate from Parkinson's disease is they typically start with visual hallucinations. There may be some memory impairment at that time, but it's really not usually noticeable to the family or other people. We're doing on time. Going to break.
How's his gait? And is it like that cerebellar? Does he have any of those that cerebellar gait, that kind of wide?
He does. Yeah. Unsteady gait. But he's strong, so he will get up. But he's been agitated. They called me in because of the behavioral things, and the caregivers are really burning out. He has been seen in outpatient geriatrics, but it's hard to do some of it outpatient when they're really going south. And so he was put on mirtazapine, which is an antidepressant, and we often do use antidepressants for behavioral symptoms. There's nothing wrong with that, but my concern is this guy has a large prostate, and they're telling me all this stuff is happening at night. So you might think about sleep apnea. He doesn't look like a good candidate for sleep apnea. He's just muscular. He's not overweight at all. No lung disease that we know of, per se. But he does have this large prostate. And he's had an elevated PSA, but the wife said she's much younger than him. So the urologist said, oh, we're not going to even test this anymore. He's gotten so demented. We don't want to do any procedures on him. We're going to leave it alone. So that's fine. But I think the problem with mirtazapine is, even though he was only on 7.5 milligrams, that is an SNRI. So it's a serotonin norepinephrine reuptake inhibitor. And serotonin can't, and with, you wouldn't think so at that dose because it usually doesn't really kick in until the higher doses. But sometimes when there's a lot of brain damage, you don't know. And so it could cause agitation and it can cause urinary retention. And I have seen that at 7.5 milligrams in older patients that I was really surprised that that was happening. So we did two things. We decided to stop the mirtazapine. We did three things. Start him on prazosin. And that's because prazosin they started finding out that it was good for people that had PTSD. And for some reason, Jerry Syke picked it up and they found out it was helping decrease agitation in demented patients with behavioral symptoms. And while that's not the main drug we would use for somebody with a big prostate, like tamsulosin, they're both alpha blockers. So that was a no-brainer for this guy, is to use the prazosin to settle him down. But you do have to be careful. The first pass, the first dose, there's a huge hypotension risk. And he did indeed have some orthostatic hypotension, but it's gone. After the first dose, it was gone. So stopping the mirtazapine and then working with the nurses to say, let's make sure he really empties his bladder at night by making sure he goes to the toilet and not just in the urinal. Have him sit on the toilet, really spend some time doing that, and do a post-void bladder scan to see. And he was much better, just in a couple days with that kind of a regimen. Now, we're not out of the woods on him yet, and he is on some Seroquel. But again, with those really bad vascular dementias, sometimes you're going to need something, at least for a while, until we can crank up the prazosin. Maybe we can back off on the antipsychotic. And I'm really hopeful on someone that doesn't have a frontal infarct that we can do that. So I think I have a slide about that. So much on Lewy body. It's complicated. You're going to have to read about it, get some help. Just be aware that it's there, and those visual hallucinations, and it's typically almost always visual. When you hear about auditory hallucinations, what do you think about? Schizophrenia. Okay. You might hear delusions, and sometimes you have to help the family tease out what's a delusion, an auditory hallucination, or a hallucination. Did she ever have hallucinations, see things that aren't there? Oh, yeah, she sees her sister. Well, does she actually see it, or she thinks her sister is there? Oh, she just thinks she's there. She doesn't see it. No. But so you have to clarify that. But they're typically just visual. And there's going to be new. They did the criteria for Lewy body just a couple years ago. They kind of upgraded. I think we're going to see more, and we're going to see more PET scanning kind of stuff, looking for something in the visual lobes. But then there's all these other variants, and it's a whole spectrum of Parkinson's plus, and Lewy bodies in there. So then frontal temporal dementia is fortunately fairly rare, very difficult, especially the Pick's disease. They will initially, and it can be a pretty early onset. You don't see Pick's in people that are really old. It's quite familial, sort of usually onset in the 50s or 60s. And you can have like a stellar citizen suddenly is doing weird, bizarre, antisocial behaviors, stealing things, sexual inappropriate things, going up to people that they never knew on the street, talking about whatever. It's fair, and families are just beside themselves with these behaviors. I know of a case that I'm quite sure this is what happened to a neighbor of mine. And he changed his very successful business. He wanted to go into just making porn. Which, that I only learned about later from collateral history when I ran into somebody that used to work for him. And she could tell me, from the beginning to the end, it was like, the guy was on it initially. And then things just started happening, and he was doing weird stuff, and I was seeing stuff. Anyway, that ended in a divorce, and he ended up dying. It was pretty rapid onset, yeah. But, it was weird. So, and his wife divorced him. Because of these horrible behaviors and running off with a 24-year-old to Texas, yeah. So when you hear that kind of behavior change, it's like, they need to get some help. Yeah. So PICS is one variant, but then there's other types that are just, they call them semantic dementias, and that's a type of frontal variant where they start losing their language abilities. Then the temporal lobe atrophy, we described this with the patient we had, this anomic dysphagia. So they couldn't name things, but they could write it. And they have echolalia. They're easily frustrated. So one thing I did with that patient is I enlisted the help from the speech-language pathologist. I think in the hospital, in nursing homes too, we use the speech therapist for swallowing. Everything is swallowing with it, right? But they do have strengths in other areas, and they do a lot of work with stroke patients. And I had her do a complete aphasia battery, and then she was able to really identify better and came up with strategies for the staff in working with him, what they could do. And we have a multidisciplinary liaison team, and we got people in to do creative arts with him and music therapy. And when I asked him about music, do you like music? His eyes lit up, and he said, yeah. And I said, what kind of music do you like? And it was church music. And, you've heard about stroke people that can sing songs. They can't talk to you, but they can sing songs. So those are very therapeutic things that can be done with those types of patients. And using the speech therapist to help you with that is good teamwork. For frontal temporal lobe or temporal lobes, we do use the SSRI antidepressants. It can help with, especially when there's inappropriate sexual behavior, seems to be helpful. Some of them may need antipsychotics. This guy didn't need any antipsychotics, except maybe very initially. And we do use the acetylcholine esterase inhibitors. So that's your donepezil, galantamine, and rivastigmine. And it does help with, sometimes with the behaviors. We also will use, we also use these for the Lewy body patients. It helps with hallucinations. But you have to be sure you're not going to be causing cardiac problems, appetite problems. All of them have some of those side effects. And then once you know what the diagnosis is, and it's very rare, especially as outpatient or even inpatient, to really know right away what it is. And so we will usually say, well, it really looks like this, but we need some more evaluation, and we'll send them to geriatrics as an outpatient to follow and see, because they may still be sick, and usually they end up in the hospital because they're really sick, and then all these things emerge because of their dementia that nobody really noticed before because they knew who their daughter was. Okay, so naming the big D, it's like presenting cancer, right? This is a dementia, and they need to understand this so they can do some planning. When people lose their memory, they don't initially have complete lack of capacity, but they will at some point have a lack of capacity. So you need to also judge what you can do in terms of advanced care planning, which behaviors also, counseling them on the behaviors. And that's where I use the Cornell Scale for Depression and Dementia as a teaching tool, because I'll say when I worked outpatient, I would follow them for a while. I mean, probably every couple of months, start them on medication, keep testing, watching them, making sure there are no side effects after a year or so. Say, well, you don't need to come back for a year. And they're like, what? It's like, well, you can come back if there's problems. Well, problems, what, like what problems? They don't know. So I would use that tool as a way for them to identify what are the things in the behaviors of this patient that may be problematic. Now, maybe not necessarily diagnosing depression, but for them to bring it to the attention of the geriatric team rather than the PCP who has no clue what to do. Okay, and it's very important to realize that a lot of the behaviors, giving a pill for behaviors is a slippery slope. Everybody wants a pill for everything and be cured. But it's mostly behavioral, and we cause a lot of the problems. As the dementia progresses, people actually develop apathy. So as long as they're sitting in their chair, they're not agitated until you come along and say, you have to get up. It's time to go shower. Come on, you gotta get up. We have to go over the shower, and you have to get your clothes off and get wet and get, so we can go to bed and get in bed by 10 o'clock. It's like, overload. So don't do that. So we approach them in a positive manner, and we take them by the hand, and let's go for a little walk. And, showers make me feel fresh and clean. And don't try to reason, argue, and I'll show you some other typical words not to use. So teaching behavior caregivers is very important. And, the Alzheimer's Association does a lot of this. There's more and more initiatives going on about it. And activity-based care is the bomb for these people. So daycare programs are great. If they're staying home, what we find is the family's complaining that they're up all night because when they were home alone in front of the TV, they were sleeping. They have no meaningful activities, and they're bored, and they don't want them walking out, so they lock up the house, and they're just, they're not getting any activity. It's not good for them. And it's not good for the family because then they're kept up all day. Well, sometimes it's a financial issue, but it's a lot cheaper than other alternatives to go to a daycare program. They get good structured activities, they get meals, they get socialization, they can have their medications there, and then they're tired and they go to sleep at night. So we really try to push that, and it gives the caregivers, even if the caregivers are home, then it provides a break for them. Okay, so behaviors, ruling out all the problems, maybe, but avoid the knee-jerk UA on all those patients, right? We had that discussion. But other medical problems can be exacerbating their cognitive symptoms when they're in heart failure. And avoid treating side effects of drugs with another drug, which is the prescribing cascade that's so common in geriatrics. I don't think I had that much more, but do you want a break? It's always good to be able to, again, dementia is it's another chronic disease. It's very common. Like I said, people 85, by 80, 20% of the population has an irreversible dementia. By 85, it's almost 50%. Very common. So many families are dealing with it, and they're dealing, they're dealing with their older parents, and they're dealing with kids. So this is a sandwich generation. They're dealing with both things, and it's very stressful. And most people haven't done much planning. We're going to talk more about planning in a minute. But just teaching families how to cope with it and get resources for them, and making referrals to as many things as you can possibly think of, and get, social workers, Alzheimer's Association. They don't have to have Alzheimer's disease to use the Alzheimer's Association. It's called the Alzheimer's and Related Disorders Association. A lot of good stuff on the website, but they also have local chapters, and they have resources there, and that changes from time to time, but they might know about some of the resources in the community, some kind of help. Mobilizing family members. When they don't realize that they're demented, they don't think about mobilizing, and then sometimes they get so burnt out they just can't get the energy together to do it. I mean, and we've all been guilty of that, right? It's like you really need some help, but you're just going to slog through it, burn yourself out. So trying to keep their environments, clean, reduce the noise, but they need activity that's appropriate for them. And with the apathy I was talking about, you can see it earlier in the disease, but it's more as the disease progresses. And they actually have programs in some of the nursing homes and the daycare programs called Namaste. Anybody heard of that? So these are programs for really advanced dementia patients. So most of them are nonverbal, or they say very few words, but they respond to gentle music, and they do aromatherapy and lotion on the hands and warm washcloths on the face. So really using sensory stimulation for them is very good. And that can really reduce agitation for these people too. And it's humane. I mean, it's not too hard to figure that out. But it's been very popular. That was developed actually by a social worker, Joyce Samarn. Lots of programs around here are doing that, in Hawaii too. Okay. And I was talking to one of your classmates here about our multidisciplinary liaison clinic. When I didn't mention, I talked about the creative arts and those things. They also have people that come and do massage and aromatherapy, and they have behavioral health behind them. So we have nurse practitioners involved in that service, looking at assessments. Some of the residents are involved, right? Yeah, so psychiatry, and when we really pull out the guns, we try to get the geriatric psychiatrists down there. But that's a very scarce resource, so hard to get. Anyway, communications techniques, and you will find this violated all the time. Could you just tell her to stop asking me those questions all the time? Or why does she keep asking me the same question over and over again? Tell her she has to remember whatever, right? No, she can't remember. I mean, you actually have to teach people this stuff. And also communicating with them. She's just so contrary. Her memory's selective, and she just doesn't agree. She just argues with me about everything. It's like, stop arguing. It's not effective. It's like, so there's actually a book. It's a short read, and she has the 10 Commandments. Joe Huey's book is called Alzheimer's Disease, Help and Hope, the 10 Commandments. And you can use those 10 Commandments with credit. You can use it for handouts. I did, my past job, I did a lot of training with the nursing staff and even the nursing aides. And when we did behavior management training and we used this, they said, oh, can we put that up on the wall? And they really like that. And it's really effective. Don't argue. It's really easy. Don't argue. Instead, you agree. Don't confront. Instead, you distract. Don't belittle. Instead, you praise. It's not hard to do, and they feel much better. It's all about their feelings, okay? The person, they may have lost their memory, but they're still a person, and they have feelings. And it's very similar to what they were like before. It's just much exaggerated, and they want to hear positive things. So they can only hear positive things. Does that remind you of anybody? We won't get political tonight. That's not Okay, yeah, don't belittle it. You validate them, okay? I don't want to spend a lot of time talking about pharmacological management. It's going to be very specific to the population you work with, but just be aware that there can be help from these drugs. The drugs specifically for Alzheimer's disease, they have modest effects. They do not cure. They do not make it better. They only help slow it down. So we need to have realistic expectations on the part of the provider and the family what these drugs are going to do for them. So remember, people really like those pills. It's a magic bullet. And most of the time when I've seen people in their nursing home and their advanced dementia and they're not getting any better and they're participating less and less, I will talk to families about, and I'm always trying to cut down medications because most of the time it's not doing them any good, and you ask the family about it, and most of them will say, well, do they really need to be on that anymore? And sometimes they'll even say, it's really expensive. Whether they're paying for it or not, they just think, why are we doing this? But I always check with the family before I stop it because there are a few that are very married to that, and they will say, and especially with Namenda, which is for later stages of Alzheimer's, we use the donepezil, the anticholinesterase inhibitors, early in the disease. And we can, and we're testing and we can see that. But by the time they're getting to use Namenda in the moderate to especially advanced disease, advanced stages, it's very hard for us to measure what the drug is doing. So we kind of leave it to the family as far as what subjectively do they see the benefits being. And sometimes they'll tell you, well, I think she's more conversive, or she's more functional, she feeds herself better. And that's fine, and maybe the behaviors are better. So if that's what they are reporting and they truly believe that, who are we to take it away from them? Unless there's really bad side effects. And they will tell you the side effects. So those GI side effects are more like nightmares. There's more GI side effects with the anticholinesterase inhibitors than the NMDA receptor agonists. Okay. Again, with the behaviors, sometimes it's appropriate to treat. Again, if the behaviors are being, because of depression in the dementia, that may be very appropriate to treat them. And we often see very good responses with antidepressants. We tend to use citalopram as the go-to, has the most evidence. Lexapro is basically the same drug, but it's only one isomer, so it's probably cleaner. But the evidence in the literature is from citalopram, so they tend to use that. After 20 milligrams, you really have to be careful with the QTC interval. So we usually check EKGs before we start them, and we'll monitor the QTC interval. But especially for frontal temporal dementia patients and a lot of patients, 30 milligrams is really going to be the target dose to really get effects. So you're going to have to do another one. You've got to look at the QTC and see where you are with that. And again, educate the families on the risks and the benefits. The antipsychotic drugs have significant risks. So if you are using them, I always counsel and document with the caregiver or the decision maker that these drugs do carry significant risks with increased cardiovascular mortality in the form of a heart attack or a stroke, in the language they can understand. But the benefit is maybe they can go to a care home or a foster home and get out of Kekela. Because if we don't control the behaviors, nobody's going to take them. And the family doesn't want to take them either. Or they can't. Anti-anxiety medications, again, benzodiazepines. So, I mean, it's kind of a good give and take. I do a lot of work with the psych department. Psychiatry, they're not geriatrics. We have virtually no inpatient geriatric psychiatrists. So we do work with them a lot. Don't like the benzodiazepines. Occasionally they talk us into it with extremely ill schizophrenic patients for a variety of reasons. And, some of them are so refractory and so ill. It's like whatever can give them comfort. I'm up for that. Anti-seizure drugs sometimes are used for mood stabilizers. Again, the Depakote has been the go-to for many years. I'm a little concerned about that. I think that we should get away from that. We actually have used Lamictal for some of these patients. That's a tricky drug to use too, but once you get it titrated up slow enough that you haven't caused a rash, it can be a very, very good drug. But I would do it with somebody else on the team too. And then if they're already on Depakote and you try to switch them to Lamictal, it's extremely painful. It takes a really, really long time to cross-titrate. I recently cross-titrated a patient from Vimpat, which is lincosamide. It's an anti-seizure drug, pretty new, pretty clean, but no benefits in terms of mood or behavior. So we really, this is a patient with frontal infarcts, wild, and he was a bodybuilder, so it's like dangerous. So he was in the psych unit for a long time. Chrissy, she knows who I'm talking about. Yeah, very interesting. Yeah, so antipsychotics should be the last resort, but maybe in the beginning you use them while you're titrating some of these other things, like the alpha blockers. You have to titrate them up slowly. We only go up maybe 1 milligram every couple of days. But sometimes we're up to 10 or 12 milligrams a day for the prazosin. And it's amazing. We've gotten some really good responses. Anticholinesterase inhibitors, like I say, they can be helpful. I'm a big skeptic, though, of the drug industry. Okay, drugs can do great things, but sometimes we're duped. Anticholinesterase inhibitors, the first one that was introduced was back in the late 90s. It was donepezil with the trade name of Aricept. Start at 5 milligrams, go up to 10 milligrams after a week. We can never do that. I mean, in my population, most of my little 80, 90, 100-pounders, we never got to 10 milligrams. We tried it, and we would have to back down to 5 milligrams. And 10 milligrams was the top of the dose. I had one guy ask me if he wanted to take more. He was a highly functional person, lots of Alzheimer's in the family, and he wanted to take more. It's like, it's not, there was no basis for that. It was approved for early to moderate dementia, Alzheimer's type dementia. So the years go by, it goes generic. Next thing you know, they're taking, you can't even get the generic, and they've got a new formulation, Aricept 23. And they got it approved for advanced dementia. Okay, I'll get off my soapbox on that. Maybe it's not all about money. So, what's that? Yeah, it's a big. So, you know, we want our drugs. There's a lot of good ones out there, but I'd like to be careful about using new drugs. So, 1997 it was approved. It went generic in 2011. It's been that long already, 6 years ago. And they have the 23. And then there's 2 others in this class, rivastigmine, and initially it was just in pills, called Exelon was the trade name. Now it had a lot of GI side effects, so we tended nobody used it. Nobody was using it because of the excessive GI side effects. So they came up with the patch, which has a place. I think that's actually a very good idea. It did decrease the side effects, except there was a problem. If you don't teach people how to use it right, they come in and they've got 14 patches on their back. It's like, really? So I don't know if you've seen it, but there's actually a diagram now that comes with it. It's usually in the medication administration book. So it's one day you put the patch on here, you take it off. The next day you put the patch on. Okay, it's however long it lasts. So the patch usually lasts 24 hours. And that can be titrated up too. And then the other one is galantamine, which is Razidine. And I haven't seen that drug in a long time. I don't think they got with the program with the new updated use as far as using it for later stages or the new generic. I mean, a new proprietary name or higher doses. And or maybe it's because the drug rep for this one left town a long time ago. Could be any of those. So they all have the potential to cause these GI side effects, the cholinesterase inhibitors. And by the way the cholinesterase inhibitors work is, you know, acetylcholine is a really important neurochemical for your memory, right? So the cholinesterase inhibitors, they don't make more acetylcholine. They attack the enzyme that chews up your acetylcholine. So it's trying to preserve the acetylcholine. At a certain point, there's really nothing left to preserve. So you may be getting the side effects without really the benefits. So that's why I really don't understand why it got approved for use in advanced dementia. And because in my practice, especially prior to this year, I spent 5 years in the 2 state long-term care facilities. And when I got there, I was asked every other day, Valisa, Mrs. N isn't eating. Can you prescribe Megace? Who knows what Megace is? What is it?
Isn't it like a derivative from THC or something? It's supposed to increase appetite.
Well, you're thinking of Marinol.
Oh, no, it's Marisol. Yeah.
But you're kind of on the right track.
Yeah, but it's for
because
appetite, right?
some people think it's an appetite stimulant, and it is not for elderly. So it's a hormone. It's an anti-cancer hormone. It was more used for suppression of cancer tumors with this hormonal effect. It did seem to have a side effect with cancer patients of increased appetite, and subsequently with the HIV patients. But it has not been shown in the elderly to do that. And there's no literature really. I mean, one doc said, oh, it's conflicting. It's like, not really. It's pretty clear. And if you really look at the evidence, it's not good. And now we have the Choosing Wisely program, which is a bunch of organizations that have had their boards look at all the evidence, and the American Geriatric Society has one of theirs in their Choosing Wisely program that says, don't prescribe Megace, basically, which I have never prescribed it. Like, oh, by the way, it has about a 10% incidence of thromboembolism. And I've seen people on Megace that now they're on warfarin, and they're still on the Megace. And they're still on the drug in the first place that made them not eat, which is typically an antidepressant like Prozac. What do they do? Yeah, so we don't use Prozac for the elderly. Not only does it cause a lot of appetite suppression, it also causes electrolyte disturbances, sodium depletion like crazy in a lot of people. So I mean, you could you know, people have been on it for a long time and they're doing well. It's okay. Go ahead.
Could you use mirtazapine to stimulate appetite? I've seen that being used. in certain
Mirtazapine is an
doses.
SNRI.
Yeah.
It is the only antidepressant that seems to have a side effect of increased appetite. But most experts in geriatrics will tell you it's probably because you're treating the depression. So don't just use it as an appetite stimulant. And I had an audience of nurse practitioners get really pissed off at me when I said it's not an appetite stimulant, because they always ask these questions. And so now Choosing Wisely has this thing about Megace, and they didn't talk about mirtazapine. They just talked about appetite stimulants, but I think specifically Megace has been, I think that's pretty much a dead horse now. But you still see it. I still see it in the hospital. I still get asked about it pretty often. Yeah. What do you think about Megace? Like, next? No, it's like, let's have that discussion. So the problem is, like most of them, what are they taking? And one of them is the Aricept. I mean, I can't tell you how many people I've taken off of Aricept because they're not eating. And I had one guy that said, oh, he hasn't eaten anything for the last 2 days. And they want me to prescribe Megace. He hasn't eaten anything in 2 days, and I want me to give him Megace. Now, that guy happened to be Comfort Care. I'd done a pulse with the family, didn't want him to go to the hospital. He was quite demented. And so I went and looked at the medications. And I told them what was going on. I called the family, and I said, but I want to see, you know, I think we're looking at hospice now, but I want to see what happens if we stop some of these medications. And they said, no. They actually chose to go ahead and elect hospice and have those services come in then. But I stopped his Aricept, I stopped his Wellbutrin, his finasteride, tamsulosin. There was like 4 or 5 things that we stopped. Guess what? He started eating. Okay, he continued to lose weight and continued to get more demented, and he was on hospice for 2 years. Yeah. So that was a really interesting one. But again, get rid of the drugs that are causing that. And what benefit was he deriving from any of them? It was undetectable. Yeah. So, and that's very common. I mean, he was a dramatic case, but it happens a lot. So most of the antidepressants are also anorexic, except for the mirtazapine. So we want to pick them carefully. Chantix or Wellbutrin is very anorexic. I think some people use it for that. And that's the one they use for smoking cessation. So I've got somebody asking about that one for one of my patients. Okay. The other thing I want you to be aware with this drug is it can cause or exacerbate heart block. So they'll be in bradycardia. So if you have a patient with bradycardia, better get that checked out. You know, if you don't have any EKGs on them, I would probably, I mean, these days I'd probably get one before I start it if I have any concerns about that. I've seen a couple cases where somebody has a pacemaker and they're still on the Aricept, and I'm not sure they needed it. I mean, it was very unclear that it had ever been tried to stop the Aricept. I have taken people off of Aricept and their bradycardia stopped. Now, if they need rate, let's see. Well, I guess we wouldn't use it for rate control. That would be sort of off-label. Okay, this is now this is the memantine, NMDA receptor agonist, memantine. This was a little bit after Aricept. This was originally approved for moderate to severe dementia. I think I kind of talked about how we use that. The titration, again, they had this dosage pack that over a month you would crank them up to 10 milligrams twice a day. We never found that to be possible. We would slow down that titration. And that's so much true in our frail elderly patients. And now they have the extended release formations, and it's a higher dose. Instead of 20, it's up to 28 milligrams. Again, it's proprietary. I think it has to do with money. I don't know. I'm always skeptical about new drugs. But then sometimes the new drugs turn out to be pretty good, and they have multiple uses. So with pharmacological treatments, again, most non-pharmacological first, and you want to, but sometimes you can't wait, right? You got someone that's really wild and swinging. We have to do something. So we do deal with that in the hospital. A lot of Haldol is used. Sometimes it's good. It's not always the great thing. But you want to go, you have to, really, what is the behavior that we're looking at? And again, the environment, you need to settle that down. Is it agitation? Is it irritability? Is it physical abuse? I mean, that's a real problematic one. And again, if you see those signs of akathisia, we want to be careful looking at polypharmacy. And we may end up having to use, people that are kind of violent and punching, then we may have to use antipsychotics. But we're going to try to start them also almost the same time with, I didn't know I was on call tonight. That's my pager. Okay, well, we're going to get cut off in here in a minute. So let's finish this up. So again, those black box warnings from the antipsychotics, you need to tell families about that. And we talked about Depakote already. Sometimes, I don't know that there's a lot of evidence, but I have seen some usefulness from Neurontin, which is gabapentin. Hard to dose, but it can be very helpful for not only neuropathic pain, but it's a little bit of an antidepressant, mood stabilizer. Definitely does work. And then the prazosin that I was talking about, an alpha-adrenergic blocker. Atarax, not so much, but I have a geriatric psychiatrist that I worked with that says there is some evidence. And the new Adexta, I don't know about this one. But I have seen it's approved for sotobulbar affect, which is pretty rare. But I saw him use it on somebody that was eating her shirt for 10 years and stopped it. It's usually patients that have had stroke problems. Yeah, bizarre behaviors. Okay, again, working with the caregivers, social work, and all kinds of support groups for them. And then end-stage dementia issues, you really have to counsel families. If you're doing this as an outpatient, you can't expect that they're going to know automatically what they need to watch for. So you kind of have to look at, what's the most important things for safety. Initially, it's probably going to be wandering kind of things because they're really mobile. Then the medications, bathing, monitoring, even constipation. So how are her bowel movements? I don't know. She does it herself. I think she's really constipated right now. And then counseling on end-of-life issues. So if you catch people really early, if you have the opportunity to see people when they turn 65 would be a great time, and I think there's probably benefits, and there's even like credit now when they come into the Medicare program to have these discussions about advanced directives. You want to do that. Don't wait till they need a pulse. They need decision makers. That's the most important thing. Discussions with families about what they want and anticipatory guidance. Counseling on those end-of-life issues, especially when they have, if you do know they have an early dementia, to have some discussions about that. Some of them will tell you very clearly. It's way off into the future for them, but they will tell you exactly what they want and they don't want. And they can execute an advanced directive. Just because you have a diagnosis of Alzheimer's doesn't mean you have no capacity. Talk about how things go because they're worried about people starving to death. So that's probably the number one thing I would ask you to think about. Counseling them on is the natural progression of the disease. They stop eating and drinking. No, they're not dying from not eating. They're dying from their Alzheimer's disease. And it's very clear that the feeding tubes do not make people better. We're going to get cut off in a minute. So address those goals of care, and I think that's about it. And this is a great website for you to know about. They've got chocked full of references that you can use for education with families about what is CPR, the risk and benefits of CPR, feeding tubes, and so forth. Okay. And then transition to hospice when appropriate. And again, Kokua Mau has a lot of issues on that. We have a lot of liaisons that come by the hospital and have them talk to family members. All right.
Thank you so much, Valisa, for coming and guest lecturing. That was terrific. Thank you. Obviously, very complex patients you have every day.